Everyone, today we are going to cover Crohn disease. So it's a chronic inflammatory bowel disease that affects anywhere from the mouth to anus, unlike ulcerative colitis, which stays in the colon. Crohn is unpredictable and can show up anywhere in the GI tract. So Crohn disease has an unclear etiology, so we think it's a mix of genetics, immune dysfunction, and environmental triggers. So what makes it unique? So transmural inflammation. It affects all layers of the bowel wall and not just the mucosa. This is why we see different complications than ulcerative colitis. The disease shows a patchy distribution with skin lesions, areas of diseased bowel separated by normal tissue. Most commonly affects the terminal ileum, but remember, it can be anywhere. The classic triad is diarrhea, weight loss, and abdominal pain. So the pain is often cramping, commonly in the right lower quadrant when the terminal ileum is involved. But Crohn isn't just a gut disease. We see extra intestinal manifestations like eyes. There will be uveitis or episcleritis. Joint arthritis can mimic inflammatory arthropathies in the skin. Erythema nodosum, those painful red nodules, or pyoderma gangrenosum, so those nasty ulcerating lesions. So weight loss happens from malabsorption, decreased appetite, and chronic inflammation. Burning calories. Severity varies widely between patients, so presentation really depends on disease location and extent. So diagnosis needs endoscopy plus imaging. On colonoscopy or upper endoscopy, we look for three key features. First, skin lesions, so that patchy distribution I mentioned, and deep ulcerations, unlike the superficial ulcers in ulcerative colitis, and the cobblestone appearance. The mucosa looks bumpy from submucosal edema and intersecting ulcers. So imaging with CT or MRI intergraphy shows bowel wall thickening, inflammation in areas we can't scope, and helps identify complications like abscesses or fistula. So labs show elevated inflammatory markers such as CRP and ESR, and fecal calprotectin is elevated, indicating intestinal inflammation. So checking for anemia from chronic disease or iron deficiency. So treatment has two goals: to induce remission and to maintain it. So for acute flares, first line is corticosteroids, prednisone and budesonide. They work quickly to reduce inflammation, but we can't use them for long term due to side effects like osteoporosis and diabetes, as well as weight gain. So for steroid sparing, we use thiopurine analogs such as azathioprine or 6-mercaptopurine. So these are immunomodulators that take weeks to work but help maintain remission. So biologics are the game changers. So anti-tumor necrotic factor agents like infliximab, adalimumab, these are especially important for moderate to severe diseases or when other treatments fail. So, newer biologics target different pathways like vedolizumab or ustekinumab. So, the goal is to decrease flare frequency. So the critical point is that surgery is eventually needed in about 50% of patients, and the surgery in Crohn's is not curative. Complications can be malabsorption leading to iron deficiency in other vitamins, as well as a structural fistula abscess and increased colorectal cancer risk. So if you find this useful, like, subscribe, and share it with your friends. Thank you so much.